Hello everyone, I'm Sarah Stabler, infectious disease specialist at Lille University Hospital, and today I will presenting on vaccination in patients with autoimmune inflammatory disease who are receiving corticosteroid, immunosuppressant or biologic treatment. The talk will explore how we go from guidelines to clinical practice. We'll start with a short reminder on vaccine before scanning current recommendation and trying to answer some practical concern. Let's begin with a short reminder on how vaccines work. Vaccines are antigenic preparation that induce a specific immune response against a target pathogen. This response is maintained over time, even in the absence of the pathogens, thanks to immune memory. The vaccine landscape has evolved significantly from first live attenued vaccine to RNA vaccine, such as those used against COVID-19. To resume, there are three main categories of vaccines. Live attenued vaccines, such as MMR, varicella, or yellow fever, that confer rapid and long-life immunity but are contraindicated in immunocompromised patients. Non-live vaccines, such as shingles, influenza, or pneumococcus vaccines, that need several boosters and sometimes adjuvants but are not contraindicated in immunocompromised patients, and RNA vaccine that are also not contraindicated. What are the current recommendations for patients? There are different types of recommendations. General population guidelines based principally on age, specific recommendation for immunocompromised individuals, and comorbidity-based recommendation, for example, in asplenic patients or patients with chronic cardiac or pulmonary disease. Many different recommendations exist in USA, Canada, Europa, for example, and fortunately for us, they are globally the same. Let's look at these specific recommendations. Concerning influenza, yearly flu vaccination is recommended with available formulation. It's important to note that it exists two more vaccines with a high-dose quadrivalent vaccine and adjuvanted trivalent vaccine. No specific clinical trial exists for patients with autoimmune or inflammatory disease, but a clinical trial in transplant patient recipients has compared these three different flu vaccines, and a better immunological response has been observed for the high dose and adjuvanted vaccine compared to the standard dose, suggesting an interest in immunocompromised patients. For now, these two vaccines are recommended only for more than 65-year-old patients. About COVID-19, biannual vaccination is recommended. The booster has been maintained for a spring 2025 campaign, and this decision is based on two arguments. The first one is the persistence of peaks of incidence throughout the year, and the second one is the efficacy of on current vaccine, on current circulating GN1 Omicron subvariants. Concerning pneumococcus disease, there is a new in 2024 with the PREVENAR 20, a 20-valent conjugated vaccine that arrives on the market. In case of earlier vaccination with only one vaccine, patients should be vaccinated 1 year after. And in case of complete schedule with the two-dose recommended vaccine, PCV20 should be administered 5 years later. Concerning ZOSTER, there is also new in 2044 with the recombinant adjuvanted vaccine. It is indicated for adult patients with a higher risk of ZOSTER, and autoimmune disease patients are one of them. The schedule is 2 doses spaced from 1 to 6 months apart. This is a huge step for immunocompromised patients, as the previous available vaccine was contraindicated live attenued vaccine. Live vaccines such as measles, mumps and rubella, or varicella or yellow fever vaccines are contraindicated in immunocompromised patients. If possible, vaccination should be performed before treatment initiation. If not, only very low dose of corticosteroids, less than 10 mg per day, less for 2 weeks, are acceptable to vaccinate with such vaccine. These recommendations came from one old study that highlighted an infectious over-risk for patients receiving more than 20 mg per day and a cumulative dose greater than 1 gram. A remaining question is, are all immunosuppressive treatments equal, and should they all be contraindicate live attenued vaccine? Even if American and Brazilian recommendations define a low immunosuppressive status, which corresponds to methotrexate treatment and sometimes azathioprine treatment, that can allow to consider varicella or yellow fever vaccination. In Europe, all live vaccines are contraindicated regardless the treatment. Let's now move to the clinical question we often face. First of all, why additional indications, and why do these patients need additional vaccination? The response is that they have a higher risk of vaccine-preventable infection, such as flu, invasive pneumococcal disease, or ZOSTER. This higher risk is well documented in the literature, and you can see, for example, the odds ratio from 3 different studies. Despite this higher risk, it is unfortunately observed a low vaccination coverage rate. In this French study carried out with the National Assurance Health System, patients with immunosuppressive or biological therapies were vaccinated against influenza or pneumococcal diseases for only 30% of them. Second of all, what is the impact of vaccination on the underlying disease, and does vaccination trigger disease flares? This is a very common concern. However, most of flares occurring after vaccination have been described in case reports, whereas larger studies like these ones do not confirm this risk. For example, this retrospective English study that analyzed data of patients with inflammatory disease more or less vaccinated over 10 years considers symptoms of flare occurring from 2 weeks before to 3 months after flu vaccination, and show that the risk of flares are not increased post-vaccination and may even be reduced. It is very important to note that infections themselves are likely to trigger disease flares. Do treatments affect vaccine response? Yes, several factors impact the immune response to vaccine, such as the types of vaccine, the underlying diseases, the specific immunosuppressive treatments, the age of the patients, and an individual variability. Vaccinal trials exclude immunosuppressed patients, so we have to rely on immunogenicity studies and cohort data. Studies like this one have shown reduced response to for example, COVID vaccine in certain disease and treatments. In this study, rituximab, mycophenolate, and calcineurin inhibitors were concerned, but it is important to note that still some protection remains. What is the impact of corticosteroids treatments? This very recent review of literature has shown an impact on immune response over 20 mg per day and no significant impact below 7 mg per day, suggesting that the better moment to vaccinate a patient is during disease remission with minimal corticosteroid doses. To conclude, I think that the initial consultation is a very challenging moment because vaccination should be discussed as early as the diagnosis. The goal of this initial consultation may be to educate the patient about vaccine benefits and risk, to review their vaccine history, to identify the needs, especially for varicella or yellow fever vaccines, and to provide vaccination record book. When possible, vaccinate your patient before starting immunosuppressive therapy, especially with a live vaccine. If it's not possible to delay the beginning of the treatment, use inactivated vaccines and educate your patient about exposure risk because immunoglobulins can be administered after exposition in unprotected patients. I thank you very much for your attention and for watching this webinar.